presentation. And as you said, we'll try to get down to earth again a little bit. So the idea of this presentation is to talk a little bit about not the exact technique of ESD, but what you should be thinking of. So basically, I think this is a question that we all have to ask ourselves, and we have to repeat it every once in a while because we tend to go with the routine and we forget. What kind of endoscopist are you? Because we all, when we leave ourselves, we tend to become like a worker on a conveyor belt in a factory. We try to, our mind tries to simplify life by making everything the same. So you think of every resection the same. You want to do the same steps every time. But I think we should not be like this, and it can't be like this. Okay, this is how problems will arise, and this is how actually life will be more difficult. I think we should approach every case, especially when you're doing a resection, by thinking. Okay, it's very important because you can't approach every lesion like the other lesion that you did before, although this is a tendency that the mind naturally does. So when I ask what is the first step in doing an ESD, normally the initial reply would be doing an incision or an injection. But I think really the most important step is that you really have to stop and think before you start a resection, any resection, not even an ESD, even a simple polypectomy or EMR. Well, what questions will you ask yourselves? The questions are quite a lot. The first one is, should I remove it actually? Does it actually need to be removed or not? We now know that there are many lesions that you can actually don't need to remove and you can follow up. Does it have to be unblocked? Do I have to do the effort to put it on ESD, or is it actually safer and better to do it in a piecemeal EMR for this patient? Very importantly, do I currently have the skills to do it? Do I have the tools necessary to do it? Do I have the backup necessary in this situation? How will I do my incision? Will it be semi-circumferential, circumferential? Will I do a tunnel? Will the endoscope be actually in a straight and stable position or not? How will I get traction if I need it? Will I use a clip and line? Will I use the gravity? Will there be a muscle defect? Is this a very deep lesion? So, okay, if there will be a muscle defect, then how will I close it? Then sometimes you have to think, will I actually be able to get the lesion out? Sometimes you approach a very big lesion, like 4 or 5 centimeters, and you're very happy that you removed it en bloc over a couple of hours, and then you find that you can't even get it out. So these are all really questions that you really have to ask yourself before approaching any lesion. It looks like it's very troublesome and it's a lot of work, but it actually makes your life much easier when you do actually ask these questions at the beginning. For example, these are different approaches that you can have to any lesion. You can do the classic ESD, like doing a circumferential incision. Sometimes you do a semi-circumferential incision. Sometimes you say, no, I will do like a pocket and go under the lesion. So let's take real-life examples, okay? This is a typical, it's a small submucosal lesion in the distal body of the stomach. It's about 1.5 centimeter, it's submucosal. You can here just stop and say, okay, this is simple, let's do a circumferential incision and remove it. But actually, no, even in this type of lesion, I do ask these questions. First of all, should I remove it or not? Is this actually a submucosal lesion that is less than 2 centimeters that you can leave it? Yes, it is an option. In this particular case, I did think about it, but the patient was really, really very anxious about having a lesion site, so he told me, no, I really want to remove it, even if you can leave it. Does it have to be unblocked? Of course, yeah, we have to ask this question. And yes, we knew that we should, because we did an EUS, and it showed it could be a neuroendocrine tumor, so we really don't want to leave a part of it. We ask all the questions, we have the skills, the tools, how will do my incision, so will I get traction or not? We do ask these questions, and you'll see why they're actually useful, even it appears like a simple approach for this lesion. So when we do inject water in the beginning, we make sure that the water doesn't puddle at the site of the lesion. This tells me that the gravity is actually not at this site. It's the opposite way. And then we decided to do a semi-circumferential incision, and you'll see the benefit now. Of course, doing a semi-circumferential incision, it helps first of all because this is a very small lesion, if you do a circumferential incision, whatever you inject later on submucosally will disperse very rapidly, and you won't be able to get a good lift. So especially when it's a small incision, I prefer doing a semi-circumferential incision. So you can see that throughout our cutting, the submucosal cushion is always there. the methylene blue, it doesn't fade away. You have this injection present. Now, the other advantage of having a semicircumferential incision in this part is that when the mucosa on the other side maintains traction, and since we put the patient in a position that he's against the gravity, the lesion is against the gravity is pulling the lesion away from us. So we have traction all the time while we are cutting. So we didn't even need to use any clips to traction, but you see here, only by the gravity pulling on the lesion, you have very good exposure and traction. And this injection, it didn't fade away because you did a semicircumferential incision. You still have mucosa on the other side. And you see how nice the lesion is pulled upwards only by the gravity. So thinking in this case helped us a lot to make this procedure not very complicated, and it went very quickly. This was removed in almost 20-25 minutes by the simple thoughts. And you see here there's no traction needed because you have positioned the patient correctly so that the gravity is against you. So sometimes things are much more complicated than this, but you always have to think. This, for example, is a lesion in the rectum. It's an anorectal lesion, actually. It is almost circumferential. So here we have to think of another approach, because if you just think with a rigid mind, I will do only a circumferential or semi-circumferential incision, then you will really get lost in no time. So we used here another approach, was using the tunneling. So by tunneling, you maintain your position. So if this is the lesion that's circumferential, you do a submucosal tunnel, another tunnel, eventually you do incisions, and you connect these tunnels, and you keep dissecting under the lesion, and then eventually you remove the whole lesion. Of course, it's easier said than done, but if you don't use this strategy, then you will definitely get lost, and this whatever you cut in this lesion will fall on you like a carpet. It will be like folds falling on top of you. So here we start distally, just at the anorectal junction. We open the entrance to our first tunnel. We enter into this tunnel from the anal side, and we proceed proximally as much as we can. Of course, you dissect the vessels. You have to be prepared. So then we, after we go a little bit through this tunnel on this side, then we flip on the other side, do an retroflexion. So we're trying to connect two tunnels together, like they do, for example, when they do a subway. They start two teams, one from this side and one from this side, and eventually they meet each other. So here we're starting to tunnel on the other side, on retroflexion. You open the incision and you start tunneling as much as you can in the retroflex position. Here we're going again from the anal side, and we extend the tunnel a little bit, and you see here finally the two tunnels are connecting together. And you see here the strategy is, now that you're stable under the lesion, you start dissecting sideways. So on both sides, you remove the submucosa. So this is the strategy now. You're not dissecting ahead of you like we do standardly, but now you're just going sideways on the left and right, and you do this in two tunnels until eventually you're able to remove the whole lesion. And another part of the strategy here was that there was a very small rim of normal mucosa, and we decided that we will maintain this. We will not remove it, even if it's small, because we know this will reduce the chances of having a stricture later on. So strategy is really very important, not just being able to dissect. I believe any one of us, whatever his level of expertise is, can go and dissect using a knife, but it's really about thinking what to do before doing it. This is another example of a difficult lesion that was in the lower esophagus. It was a superficial adenocarcinoma. And you can see here the nodules that are suspicious nodules. And it's overlying a long Barrett's esophagus that's taking almost half the circumference of the esophagus. So again, if you just decide to cut all around, it will be a mess. You will be lost and you won't really know what to do. So we decided also to do some tunneling. So this is the exact technique that we used. Yes, so we used initially a distal incision, and then a small proximal incision, and then do a submucosal tunnel. And then you do another tunnel beside it. And the tunnel helps you to maintain your place and not get lost. You're always under the lesion. Eventually, you will join the two tunnels together. And now it's very important that when you need to cut those, if you just cut everything, this will fall like a flap, and also it will be very difficult to remove. So what we do is that we cut, but we leave the distal corners to the end so that they maintain traction of this lesion and not everything falls on top of you. That's why we call it like the flying carpet technique. So this here is the distal incision that you do in the retroflexion under the cardia. This is distal incision, and then you do a proximal incision above the lesion, and then we start tunneling inside until we eventually reach the distal end just below the cardia. So now we've completed the first tunnel under the lesion from above, reaching down to the level of the cardia. And again, we keep dissecting on the sides as much as we can. And then we do another tunnel beside it. You see here there are two tunnels now, and then we start removing the barrier between the two tunnels. So now when you remove this, you have the whole lesion above you. It has been dissected completely except on the sides. So we have completely removed under the lesion. And then when we start removing on the sides, the remaining lateral borders, we don't just cut, we leave about 1 centimeter and then we start cutting distally. And you can see now that the traction is maintained. It's not flipping over and falling on us because you have maintained the traction. You see here, there's a point that is holding the traction in place. And you can see this is, because we have the corners still in place, this is what we call like the flying carpet. And then finally, you can easily remove these small connections, and you can remove the whole lesion. And we reach this final nice appearance of removing what we want. What appeared to be a really difficult lesion to remove was now removed easily. Sometimes you actually don't have to remove anything, or you have to change completely your approach. This is a lesion that we were thinking of doing a simple ESD, but however, when we did an injection, you can notice that it is not really lifting very well. There is central depression. However much we inject, it's still not injecting. There is something pulling it inside, whether it's fibrosis or there is some invasion in this lesion. So then it is okay to change your plan completely, because if we start to do ESD in this, I'll probably meet this fibrosis inside. It's going to be a bit difficult. So actually I stopped in this case. I came out, I told the patient, look, we didn't do the procedure. I think you either need a surgery or we can do a full thickness resection in another session. And this is what the patient chose to do, because we didn't remove it. And she actually came in another session, and we used the FTRD device, the full thickness revise. So we marked it, we captured the lesion, get it completely inside the cap. You apply the Ovesco clip, and then you cut the lesion completely. You get the lesion out, and you see here it's a nice full resection, and it's a safe resection. You have to remove the full thickness. You see all the layers like a sandwich up to the level of the serosa. And we have the full lesion, and it was sent for histopathology, and thankfully it was only a high-grade dysplasia. There was no deep invasion for this patient. So again, the plan was changed completely. And sometimes actually, you don't have to let your ego tell you that you have to do everything. Sometimes you have to remember that there is a surgeon who can do things for you. This, for example, was a patient who had a very large cyst. It's about 4 centimeters. It's on the greater curve of the stomach. So here, when we saw this, we had to think, I can do a full thickness resection and go all around, and I can then do some closure by using an endo loop and putting clips. I can do that. But when we thought, but actually this is on the greater curve, for the surgeon, it is a really easy thing to do. So what we did is that we said to the surgeon, look, we will just go together with you to help you to identify this for you to remove it. So this is what we did with the surgeons. So here we just made an incision, started the incision for the surgeon, made some marking, and then we started cutting through a full incision while the patient is doing a laparoscopy and he's looking on the other side. And then the surgeon, he took over after we did the marking and we showed him where the lesion is, and he removed it completely en bloc. And you can see here the surgical removal was easy, especially that now he sees even our markings on the inside. He can easily remove the rest of the lesion, and the whole procedure took less than 30 minutes. So for the time, I'll just pass these. My conclusion is that we really have to think. We are not factory workers on a conveyor belt. You have to think before every resection and all the questions that I talked about. You have to know there are different approaches. You have to be flexible. And you do not have to do it. I think this is the main thing that we have to work on. You have to know your limitations, and you have to think for the patient, not for yourself or the ego. You have to work on your endoscopic assessment of the lesion, because it is really the best tool to estimate the depth of invasion. You have to trust your eyes, and you have to trust it both ways. So trust it when it tells you you can remove it, and trust it when your eyes tells you, no, look, this looks like a deep invasion, you better leave it for surgery. And of course, take your time. You have to think, you have to plan and discuss, and therefore you must have a team. I can't remember how many times that my plan changed by a recommendation from a fellow, an even younger fellow. So it really helps to have a team supporting in these resections. Thank you very much.